you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. Got his wrist pain by doing over-aggressive high fives to his buddies.
One more quick CastleFest update. I mentioned last time about live Google Glass streaming and the ability for you to have an avatar at the conference.
Well, as we're learning, Glass does have some limitations. The UI doesn't yet allow on-air hangout with Glass yet, so we're going to have to do the Glass streaming. And technically, we can only have 8 people on the hangout at one time actually asking questions and controlling the avatar that's wearing the glass.
So only fellows in our Ultrasound Leadership Academy who we've tested Hangout and Glass with will participate that way.
But you know us, we love FOAMed, so we're going to have a separate live stream in HD for everybody. Our friend Rob Rogers is going to be there live and in person with all his sweet equipment helping us stream the whole thing live.
Then I'll be at his course, the International Emergency Medicine Teaching course, a week later. It turns out that there are a few spots left at that course, so if you have any interest in teaching at all, you should definitely go to their website, theteachingcourse.com, sign up, and come. They have the world's best educators there, and also me.
Yeah, people like Amal Mattu, Joe Lex, Haney Melamed, Terry Mulligan, Mike Bond, Chris Nixon, Mike Stone, and more. Just remember those off the top of my head. So go to the website, theteachingcourse.com, to check out the others. It's an awesome course. There's one in late April and the fall also.
Now, let's learn some more ultrasound physics. So, you good with artifacts? You got the basics of ultrasound physics down? If not, go back and get a stone fresher. The last 2 weeks, Mike Stone covered these things as only he can. If you got it though, let's move on. You've graduated to Doppler ultrasound. Not so basic, but with Stone's brilliance and amazing ability to simplify complex subjects, you'll get there. You'll be talking about Doppler physics at dinner with your kids and dreaming about cosines in no time. Just strap in and get your Doppler shift on with us ultrasound nerds.
Let's go ahead and talk about Doppler physics because it's an essential thing to cover if we're working on cardiac or vascular imaging. So we've all heard that before, whether it's a car honking and going past or an ambulance or whatever other example you like to think of for thinking of the Doppler shift. The idea is that frequency changes as an object is moving towards or away from an observer. So we learned in physics at some point about the Doppler shift and the Doppler equation, and it's not important to remember this at all. I do want to point out the things in the equation because I think they'll help us to understand later how to optimize an image. So 2 is a constant, and we can get rid of that. Speed is the speed of blood, so that makes sense. If the blood's moving faster, say through a stenotic vessel or through a tight valve, there'll be a higher Doppler shift, and we'll see more of an effect of that Doppler effect, and that makes sense. So speed, check. Frequency refers to the frequency of the transducer, and a higher frequency transducer will exhibit more of a Doppler shift. And you don't have to worry about why that's true. Just know that it's in the equation, and that if you wanted to reduce the amount of Doppler shift you were seeing, you could potentially switch to a lower frequency transducer or lower the operating frequency on the transducer you're using. So that's one option. Cosine is the cosine of the angle of incination. So if you have a 90-degree angle of incidation, that cosine is 0. So there is no Doppler shift when you're 90 degrees to the flow of blood. And we'll look at this in the next slide a bit. On the other hand, if your cosine is 1 because you're 0 degrees or 180 degrees, you'll see the highest degree of Doppler shift. And we'll come back to that. And I promise there's no trigonometry needed to get further into this and no calculus. Tissue propagation speed is the denominator here and is a constant as well for our purposes. So essentially the things that are modifiable are going to be the speed of blood, which is not modifiable on our part, it's modifiable on the patient's part, the frequency of the transducer, which is modifiable, and the angle at which we observe the Doppler flow. So that's really the take home from this equation. Don't worry about being able to remember the equation. If you only take away that frequency and angle have a role in Doppler shifts, then you're doing great. And speaking of angle, this is the concept. The concept is that if you have a blood vessel, and let's say that the blood is coming through the vessel this way, all right, it's flowing through the vessel like that. In order to get the truest representation of the Doppler shift, in order to get the truest representation of what blood flow is doing in that vessel, you'd like to take an ultrasound transducer and place it directly in the vessel, facing either directly towards or directly away from the flow. And that would get you an angle of inclination of either 0 degrees or 180 degrees, which, if we refer back to the Doppler shift equation, is going to get us the highest degree of Doppler shift. Now, we can't, for all intents and purposes, place an ultrasound transducer into these blood vessels, and we can't place it at a 0 degree angle most of the time. So we have to instead deal with differing our angle to try and get the best shift that we can. So this would be an example of a positive shift where, remember, blood is flowing through this way. So it's essentially flowing towards the transducer. Now, this is the angle of inclination here, that angle. And you don't have to worry about figuring that out. Just understand that the bigger that angle is, the smaller your Doppler shift is going to be and the harder it's going to be to observe flow. On the other hand, the smaller that angle, the closer you get to placing that transducer directly facing the flow or facing away from the flow, the higher your Doppler shift is going to be in terms of amplitude and ability to measure it. So changing that angle is going to be critical when you're working on Doppler imaging, and we'll see this with some examples later. Now, one of the general principles is that when you get less than 20 degrees from 0 or from 180 to the flow of blood, that essentially is close enough that you don't have to worry. So it doesn't have to be perfect, but you want it to get as close as possible to being parallel to the direction of blood flow, whether it's towards or away from the transducer. And like we mentioned just now, if it's towards the transducer, as in this case, and the blood's going this way through the vessel, that's going to be a positive shift, and it's going to display on a waveform like that with a shift up towards the top of the screen. Okay, now if on the other hand you have the exact same vessel and you took a transducer and put it at a similar angle, but now the transducer is facing this way, the blood flow is going to be facing the same direction. So that's flow basically away from the transducer. That's going to be a negative shift, and that'll get represented on the screen like this. So if you're looking at something that actually, if you're using Doppler and you're getting directional imaging off of it, negative and positive shifts tell you whether the flow is towards the transducer or away from the transducer. Many times clinically that's not going to be in question, but there's going to be times where you need to interpret these images, and it's useful to know that. Now, going back to the Doppler shift equation, if instead the blood flow is going this way and you're imaging this way, well, that's a 90-degree angle. All right, and at 90 degrees, your cosine of 90 is 0, and that's going to get you no Doppler shift. So you will not observe any flow. Your Doppler tracing would look like that with no tracing on it. You wouldn't be seeing either a positive deflection or positive shift, and you wouldn't be seeing a negative shift. You'd just be seeing a flat line, because you can't observe flow towards or away from an observer when the flow is perpendicular to the observer. So hopefully that's hammered home the point about using your angles appropriately and adjusting your angle of inclination, because that's really going to be a critical thing for Doppler imaging. Now, when you're looking at Doppler imaging, in color Doppler is just another way of looking at it. There are subtle differences. Color Doppler really tends to display the averages of the velocities as opposed to peak velocities. Beyond the scope of anything you're going to be doing to really understand the details behind that. And this is even with you doing advanced stuff, valvular assessments, doing velocity time integrals, assessing for aortic stenosis. Advanced ultrasound applications don't require the real huge level of detail behind the intricate differences between color and pulsed wave Doppler. But for color purposes, just understand that color Doppler is still just Doppler. It's displaying shifts in frequency of blood, and it's displaying it in this case in color instead of displaying it in a graphical form. So in this case, you have a positive and a negative shift, and this is a patient with a popliteal deep venous thrombosis, and the clot is actually right here. This red flow is some of the non-occluded popliteal vein with flow coming towards the transducer in this case, and this is the popliteal artery with blood going away from the transducer. And how do we know that? Well, up here is your key, and positive shifts are the ones listed up top, and negative shifts on the bottom. So in this case, flow away from the transducer is in blue, and towards the transducer is in red. And this is a typical convention. This is something called BART, or blue away, red towards. Now, this can be switched. You can invert this scale by pressing the buttons on the machine, and you could put blue on top and red on the bottom. But by convention, blue is away, red is towards, and that's what we're seeing in this case. Now, you can also look at color with non-directional information, and this is just asking the question, is there a Doppler shift? Not which direction the Doppler shift is happening, but is there a shift at all? And in this case, the display tells you that you're not going to get directional information off of it. It's going to give you one color only, which is going to tell you whether or not there's flow. Now, the higher flow is going to be a brighter, lighter yellow, as opposed to the darker flow down here, which is going to be more of a dark maroon. And you can see that even in these vessels here, where the center of the vessel that you're imaging has that nice bright yellow and the outside has the darker maroon because it's lower velocity. So there's information even within a single color, but in this case we're looking at a midline transverse view of the testicles, and on the right testis we have flow, and on the left testis we don't, and this is a patient with left testicular torsion. In cases where you're looking for low flow and you just want to determine, is there flow in that area? Is this a Doppler shift or not? Directional color doesn't really help you that much, and non-directional color, power angio or color angio, which is what we're looking at here, this can give you the ability to detect lower velocity flow and less flow than you'll detect with directional color power Doppler. The way to remember it is just the machine doesn't have to worry about processing which way the blood's going. It's just looking for, is there blood moving? And as a result, it's more sensitive for low flow states. Now, orienting to the display screen, we already covered blue away, red towards. So that part's done, and that's up here, right? So we still know that blue is away and red is towards. Now, there is more information within that, and if you look up top, the higher velocity flow here is going to be brighter yellow. The higher velocity negative shift is going to be a lighter blue. You're also seeing that it's giving you the scale up here. So this is giving you 59 centimeters per second down to negative 59 centimeters per second. So remember, velocity has direction as well. It's not just speed. So it's got the vector included. And in this case, we're looking at the color flow imaging on the top part of the screen. And this is just directional color power Doppler. And it's using the scale that we just covered. Now, what we're doing in this screen clip, though, is actually something called triplex imaging or spectral Doppler, where we have a B-mode image here, so just the grayscale image in the background. We have a color image on the top, and then we've applied Doppler to it as well, in this case, continuous wave Doppler. And the continuous wave Doppler, which is featured down here, plus the color, plus the 2D is 1, 2, 3, and is either known as triplex as opposed to duplex with two modes, or spectral Doppler. And what we're seeing in this continuous wave tracing is that it's largely a negative Doppler shift we're looking at, and we're measuring the peak of that negative Doppler shift there. And this is tricuspid regurgitation that we're measuring, which is giving us, based on the velocity up here and the integrated calculations in the system, it's giving us a peak gradient of 57.5 millimeters of mercury, which when added to the central venous pressure or right atrial pressure will give you the patient's pulmonary artery systolic pressure. So lots of great information you can get from doing this. The display screen is telling you all of the active modes in this case. We know we're in echo. We have a sector 4-2 probe we're using. The depth is at 18 centimeters. It's telling you the settings on your 2D mode right there. It's telling you what your color settings are, and it's telling you your continuous wave settings. So there's a lot of information when you get onto these screens. The last thing to look at is the scale over here. So we already saw the scale on the color flow is set at negative 59 and positive 59 centimeters per second. And then with continuous wave, we're looking at a scale that's running from negative 400 to positive 200 centimeters per second. So higher velocity imaging able to be processed with continuous wave, and we're going to talk about that next. Continuous wave Doppler is a really interesting mode. It actually requires two crystals inside the transducer at least, and one is constantly transmitting ultrasound pulses into the tissue, and it's not even a pulse, it's a constant beam, a constant stream of ultrasound transmission, while the other crystal is constantly listening. And that flies in the face of all the other imaging that we do, where you pulse, listen for a long time, pulse, listen for a long time. Continuous wave is just that, it's continuous. And what happens there, the greatest advantage of having that continuous pulsing is you can measure really high velocities very accurately. And there are certain structures in the body, all of them cardiac, that you can't measure with pulse wave Doppler very well, and largely transvalvular gradients. It's difficult to measure aortic velocities and tricuspid velocities with pulse wave Doppler alone. So continuous wave Doppler is employed frequently in cardiac imaging. Now, the primary disadvantage is that you can't tell exactly where the velocity is coming from along this plane. So you have this spike that you're measuring velocities along, but you don't know if the velocities are coming from down here or if they're coming from up there. And this is something called range ambiguity. It doesn't really matter for our purposes because we're almost always using continuous wave Doppler in the setting of triplex imaging. So you've used color to find where the flow is coming from, and in this case you're able to see that it's coming from tricuspid regurgitation. And then you're measuring continuous wave Doppler along that plane. You're pretty convinced that the negative shifts along that plane from an apical 4 are going to be due to the tricuspid regurg. So it is a limitation when you're using those old school continuous wave only transducers, but in the setting of doing it with triplex imaging with a phased array transducer, it's not really much of a limitation. But so that's the principle behind continuous wave: higher velocities, some range ambiguity, but it doesn't really have a practical implication, the ambiguity, on our general practice. Now, pulse wave Doppler, on the other hand, is very similar to all the other imaging that we do. There, you can do it with a single crystal, although obviously most of the machines that we're using have many more crystals than one. And the crystal pulses and then listens for returning echoes. What you do is you position a gate, and you don't really see it so well in this image, but this line will come down, and you've all seen this before, where you've got this area in the pulse wave Doppler, and this is the gate right here. And you position that gate on the area that you want to sample, and it's called a sample volume as well as a gate, so those terms are typically used interchangeably. You can position the sample volume or position the gate, and you put it onto a 2D image, or in this case onto a 2D image with color overlaid. So again, we're doing spectral Doppler or triplex, and then the ultrasound system will look at the Doppler shifts just at that sample volume or at that gate. So you know exactly where it's coming from. It doesn't have that range ambiguity that you'd have from continuous wave Doppler. But the disadvantage is you can't measure as high frequencies. So what we're seeing here is a scale on the side of the screen that goes from to about 140 centimeters per second. And if you remember from that last slide, the continuous wave Doppler, it was up into the range of 400 and can go even higher than that. So pulsed wave Doppler doesn't measure quite as high velocities as accurately, and you'll run into aliasing, which we'll look at next. But it does let you sample exactly from the depth that you're looking at. So those are sort of the reasons behind why you would choose pulse wave versus continuous wave. Practical purposes, in the extremities and anywhere outside of the heart, you're going to use pulsed wave. You'll use pulse wave for some applications in cardiac imaging, which Mike will end up covering in the advanced cardiac stuff. And then you'll use continuous wave for a bunch of the transvalvular velocities as well. This is aliasing. This is what happens with pulse wave Doppler when it can't handle the high velocities that you're seeing. And it gets confused as the velocity of the Doppler shift exceeds the Nyquist limit, which is the speed at which this happens, at which aliasing happens to the signal. And here's the baseline. And you've got the systole here, and then diastole, and systole and into diastole. But at systole, you're starting to see the peak of systole show up as a negative amplitude. and as a negative Doppler shift. And that's aliasing or wraparound. And that's just a function of pulse wave Doppler being unable to handle these high velocities. So if this happens, there's a few ways that you can try and get rid of aliasing. One would be to just increase your scale. So if you're able to increase your scale or bring the scale up as high as you can, then you're going to end up potentially shrinking the size of this tracing enough that it'll fit on the screen without aliasing. You can also try and get a different view with a shallower sampling depth. So when your sample volume or your gate is close to the skin surface, aliasing will not happen at the same frequency. You'll be able to tolerate higher frequencies without aliasing. So that's one way you could consider reducing it. But most of the time we're measuring our pulse wave Doppler signals, and we're placing our sample volume and our gate from the best window we can. So it's not that common that we can obtain a better view where the structure is now more superficial and we're able to get a better look at it without aliasing. Another thing you could do would be to switch to continuous wave. So that's an easy option, is switch to continuous wave Doppler, and then you should be able to measure it fine without aliasing. And then the last thing you could do would be to adjust the baseline. And in this image, I picked this one because it's already adjusted for us. And you can see that the baseline is actually closer down towards, that's a horrible tracing of the baseline. Here we go. The baseline is actually closer down towards the bottom of the screen than it is towards the top of the screen. And you can move this baseline up and down. So if you brought the baseline down to here, you may then have a good signal tracing that looks like this, and it all fits on the screen. Keep in mind that the baseline manipulation is just a visual way of trying to get aliasing to go away. It's not changing anything about the fact that pulse wave is pretty much maxed out and can't tolerate higher velocities. But that's neither here nor there. You can adjust the baseline to try and clean up your image, and that's just fine. So it's enough about advanced cardiac physics and Doppler physics. What I'm going to show you guys next is what I'd like you to try and do on your own. And it's something that I call the carotid challenge.
Hold on there, cowboy. I think we're all Dopplered out. Let's save that for the last physics lecture of the month, Advanced Physics, next week. We'll wrap this physics month up and give you the challenge at that time. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.